Good evening, everyone. Am I audible to everyone? Okay.
Yes, sir.
So first of all, a very warm welcome to all of you to the new batch of Secrets Unveiled PACES. Let me give my introduction. I am Dr. Atunude, and I'm going to guide you through this course. I'm the founder and the mentor of this course. And I'm truly delighted to see such a motivated group of doctors here today, all with a common goal: to clear PACES and to become better clinicians. Let me start by saying something very important. Actually, PACES is not just an exam. It's a test of how you think, how you approach a patient, and how you communicate your clinical reasoning. Many of you have knowledge, you have studied, you have seen a lot of patients, and you have prepared well before. But the real challenge is PACES is not what you know. It is how you use that knowledge in a structured and confident way. And truly speaking, it is a very doable exam. It is not that much difficult that we used to think it. So what makes this course different? In this course, we are not going to focus on random case discussions or superficial learning. We are going to focus on something much deeper. It is the art of structured history taking and clinical thinking. May I know, is my voice clear to all?
Yes, sir.
Okay, thank you for making it confirm. So what I strongly believe is that what mind does not know, eyes cannot see. If your mind is not trained with the right structure, you will miss the key points, even in a single case. So our core method is prompt-based approach. Here you will learn through a unique prompt-based system. Okay, I'm going to discuss it in detail. These prompts are not just questions, they are structured pathways that will guide your thinking in every scenario. By the end of this course, you should be able to approach any long case systematically, think logically and confidently, and avoid missing clinical diagnosis. What I expect from all of you is that this is not a passive course. If you want real improvement, you must be active. You have to practice regularly, and you have to report me every single day. And you have to make mistakes, because without mistakes, you are not going to learn. And we all learn from mistake. And above all, you have to trust the process. Because transformation does not happen by just attending the session. It happens through consistent practice and correction. And what you can expect from me, that is from my side, I promise you that I will give you honest feedback. I will give you a structured teaching, and I will personally identify all of your weak areas through continuous guidance until you improve. I will push each active candidate when needed, where needed, because that's what you need to succeed in PACES. And all of you are here today because you have the potential to pass the exam. The journey may feel challenging at times, but if you follow the system and stay consistent and believe in your preparation, you will succeed. So let's begin this journey together. Before starting our session today, I would like to have a discussion of our MRCP PACES examination stations, because we are at several levels of examiners here today. So the MRCP PACES exam comprises of 5 stations. They are station 2, 1, 2, 3, 4, and 5. In between each station, you will get 5 minutes of gap. Station 1 comprises respiratory, short case, and communication. Station 2, long clinical consultation. Station 3 is cardiology, short case, and neurology short case. Station 4 is abdomen and communication. And station 5 is long clinical consultation. So in this course, we will solely focus on preparing for the long clinical consultation. That is station 2 and station 5. And these are the most important stations for passing in the MRCP PACES exam. We will start from the very basic to the most advanced, and you will get it with the progression of this course. So what is prompt? Actually, prompt is the given symptom. Like in station 2 or station 5, before entering the station, in a white paper, you will be given a symptom of a patient. Like Mr. Alexander has come with swallowing difficulty. You will be given certain vitals, and you will be given instruction to talk to Mr. Alexander, examine him, and meet his concern. So this is how the question is given. And you will be given 5 minutes at hand to take preparation. You will have a paper, a pencil, and a rubber. You can write anything you want at that paper, and you can carry that paper with you inside. So prompt is the given symptom that is given from outside, like joint pain, chest pain, palpitation, abdominal pain, swallowing difficulty. So in this course, first we'll learn how to take history for each individual prompt, like the joint pain, palpitation, abdominal pain. In this course, we are not going to rush into random practice because personally, I don't support this kind of approach. So there are lots of prompts in our practical life. But if you notice the pattern of PACES exam for the last 4 years, you will be able to identify certain prompts. And I have done this personally. So there are about 73 prompts. They have been identified over the last 4 years. I have divided the prompts according to each system, like the neurology, gastroenterology, musculoskeletal, cardiology, respiratory, and renal. Total, there are 73 prompts. And you will be happy to know that in this Type 1 exam, we had more than 95% common cases exactly from these prompts. We are going to discuss today the gastroenterology prompts. So let me show you. These are the gastroenterology prompts. Among the prompts, again, we have divided the prompts into 3 categories. The most important 1 categories are the triple star prompt, then double star, and the least important are the 1 star. They are given stars according to the importance of the given prompt. Like dysphagia is a very common prompt for the PACES exam. Also the hematemesis. That's why they have been given triple star prompt. And you can see from the previous year's question how much time dysphagia, hematemesis, loose motion, these cases have come very frequently. So in this way, we'll start the discussion. So before starting the prompt session, I would like to have some discussion, that is the introductory session. The introductory session is basically on the mark sheet. And in this course, we train every active candidate to think like an examiner. And they have to practice each day how to give mark to each other using the mark sheet. So this is the PACES Long Clinical Consultation mark sheet. At station 2 and station 5, there are 2 examiners. Whenever you are going to enter the room, you will find 2 examiners. One of the examiner will greet and make you enter inside. And another examiner is the passive one. He's going to sit there all along. Both of them will carry this mark sheet at their hand. Here, the diagnosis will be written. You will not be able to see the diagnosis. This one station comprises 28 marks with 7 skill. And each of the examiner has the capacity to give you 14 marks at best. Your marks are going to be given by combining marks from both the examiner. That is 14 plus 14. After that, you are going to get 28 marks. That is how the marks are given in the long clinical consultation. So, I'm again telling, each of the examiner has the capacity to give 14 marks at best. And these 14 marks are divided in the 7 skills we are going to discuss in details today. So what are the skills? I would like to tell the candidate that if anyone at any part of the time face any problem in understanding anything, please stop me at that time.
Sir,
So our first, yes, doctor.
is LCCs from Royal College or its center base?
Not at all, doctor. If you take preparation based on the center, surely you are going to suffer.
It's from Royal College.
Sometimes cases can be repeated, but I will suggest every candidate not to be center focused, because this prompt-based approach will also help you in your personal life. Like whenever you are going to see any patients, you have to know how to take history. It is not on center based. This is absolutely wrong.
I mean, sir, I meant to say like it's calibrated, na? So calibration come from Royal College. Are they calibrated at that time?
Actually, I am not aware how the calibration comes.
Okay.
Because it is only known by the examiner, and I'm not an examiner itself.
Right.
So, shall I proceed?
Yes, yes.
Okay. Thank you for asking the question, doctor. So, our first skill is physical examination. Before describing this skill, I'm going to introduce you a very wonderful conception, that is the triple CA. And this is one of the special characteristics of this course, that is the triple CA. In this whole course period, we are going to train you how to formulate this triple CA. Actually, what does this triple CA mean? Triple CA means first C for confirm, that is confirm the diagnosis. Second C is find out the cause or trigger of the diagnosis. Third C is finding out the complications. And last A is finding out the association. And all of this triple CA has to be found out by yourself from the history, from the physical examination, and from the investigation. Let me give an example. After that, it will become clear. Today, we're going to discuss the approach to swallowing difficulty, that is the dysphagia. Suppose you have been given a case of dysphagia and the diagnosis came out as myasthenia gravis. So, from the history, first we have to formulate this triple CA. That is, first we have to confirm our diagnosis of swallowing difficulty. That is actually the type of dysphagia in myasthenia gravis is oropharyngeal dysphagia. We are going to discuss in detail today what is oropharyngeal dysphagia and what is esophageal dysphagia. So from our history, we have to confirm that it is a case of oropharyngeal dysphagia. And how to confirm it? Actually, oropharyngeal dysphagia starts with the swallowing. We are going to have a detailed discussion of it. It starts with the swallowing, and patient has nasal voice, nasal regurgitation. All of the features are there. Then we have to find out the cause. The cause of this oropharyngeal dysphagia is myasthenia gravis. So, from the history, we have to confirm the features of myasthenia gravis. And the screening question of myasthenia gravis is fatigability or weakness that is increased at the end of the day. And after that, you have to cover all other symptoms of myasthenia gravis. There is a wonderful mnemonic for that. In this whole course period, we are going to discuss with you multiple mnemonics. The mnemonic is 2D. Sorry, rule of D. For eyes, there are 2 Ds. For mouth, there is again 2D. For chest, there is 1D. For arm, there is 1D. And last D is drug history, driving, and medical address slate. So for the eyes, what are the 2Ds? 1D is drooping of eyelids. Another D is double vision. Sounds clear, doctors?
Yes, sir.
Okay. You can also give a thumbs up reaction in the comment section to make it clear. Then in the mouth, there are 2D. 1D is dysphagia. That is our given symptoms. Another D is dysphonia. That is change in voice. In the chest, there is difficulty in breathing. That is breathing failure. In the arm, the patient has evidence of proximal myopathy. So difficulty in combing here. And there are some drugs that can exacerbate myasthenia gravis, like azithromycin and something like that. If there is double vision, we have to stop the driving and we have to offer medical address slate. I have just discussed this in detail. We are going to discuss it in our neuro prompt session. So this is how we have to we have to find out the cause of our diagnosis of oropharyngeal dysphagia. So this comprises finding out the cause of our diagnosis. Let's come to the third C. Third C is complication. So can anyone tell me what is the complication of myasthenia gravis? What is the most dangerous complication?
Respiratory involvement.
Yes, doctor?
Respiratory involvement.
Yes, doctor, respiratory involvement. So from the history, we have to rule out that. We have to ask the patient, do you have any breathing issue? This is one of the complications. Our given prompt was swallowing difficulty. Can you consider any other complication of this swallowing difficulty? Whenever you are going to... Wonderful, doctor. Dr.
Pneumonia.
Yes. Thank you very much, doctor. Aspiration pneumonia. So from the history, we have to rule out that. How to rule out that? We have to ask the symptoms of pneumonia. That do you have any cough? Do you produce any film? That is productive cough.
Fever.
Yes, doctor. Thank you, doctor. So this is how we have to rule out the complication. Last is association. That CCCA. We all know that myasthenia gravis is an autoimmune disease. So we have to rule out all other autoimmune association. There is a mnemonic to remember all the autoimmune disease. The mnemonic is DAT, CPR, MV. Here D goes for diabetes, A goes for Addison's disease, T goes for thyroid disease, C goes for celiac disease, P goes for pernicious anemia, R goes for rheumatoid arthritis, N goes for myasthenia gravis, that is itself the disease, and B goes for vitiligo. So we have to know the screening question of each. The screening question of diabetes is polyuria, polydipsia. So we have to ask, what about your thirst? What about your urine output? To rule out Addison's disease, we have to ask the symptom of postural hypotension. That do you feel dizzy standing from the sitting position? To rule out the thyroid, we have to ask, is there any weather preference? To rule out the celiac disease, we have to ask, do you have any loose motion that is related to the bread, pasta, barley? Then for pernicious anemia, we have to ask, do you think you are getting pale day by day? For rheumatoid arthritis, just ask, do you have any joint pain? The case is itself myasthenia gravis. For vitiligo, ask whether there is any skin lesion there. So this is how we have to rule out the association from the history. And this way, only from the history, we have completed the 3CA formula. Let me ask from the candidate whether anyone has any question from the history portion. Then we'll discuss how to rule out the CCCA from the physical examination and from the investigation and management.
So for Addison's disease, what did you say? I didn't get the history of the Addison's disease.
Okay. The screening question of Addison's disease is symptom of postural hypotension.
Okay, sir.
And the question is feeling dizzy standing from the sitting position.
Okay.
Sir, what is the first C, sir?
This one, this is celiac disease. Oh,
No,
sorry.
sir. The first
C.
triple CA, first C was.
Confirm. Confirm the Clear, doctor?
Yes, sir.
Okay. Okay. The sound is full. Okay. So in this way, from the history, we have ruled out the triple CA. Now let's come for the same case of myasthenia gravis, how to rule out it from the physical examination. That is triple CA. Our case was a oropharyngeal dysphagia. And truly speaking, there is no physical examination to confirm the case of oropharyngeal dysphagia. You cannot tell the patient to take a sip of water to see whether the patient coughs or not, whether the patient has nasal regurgitation or not. This will go against the welfare of the patient. So here, no physical examination is needed to find out to confirm the diagnosis. And this is true for every case. For every case, you will not find all the components of triple CA, but we have to look for that. Then come for the cause of the diagnosis. The cause is myasthenia gravis, and it is an autoimmune disease. So we have to do all the steps of examination to confirm that this is a myasthenia gravis. In this course, we are going to give you a set of examination sequences for each of the cases separately. This is the myasthenia gravis examination sequence. I suggest to start with the ceiling test. Then look for frontal wrinkling, drooping of eyelids. We have to raise the eyelid and look at the pupil, because one of the important differential diagnoses of ptosis is third palsy, and myasthenia gravis patient will likely have ptosis. Then we have to check the edge movement, close eyes tightly, puff your face, all that stuff. We are going to discuss it in details when the case arises. And every active candidate, and type 1 and type 2, is going to have this format. So this is the examination sequence to find out the cause of our diagnosis of oropharyngeal dysphagia. Now come to the complication. So can anyone tell me what physical examination is needed to find out the complication? Any volunteer?
Just auscultation.
Yes.
Vital sign. Just auscultation.
Yes. Auscultate, looking for aspiration pneumonia.
And single breath count.
Yes, doctor.
Aspiration consolidation.
Yes, single breath count, or you can just say forced vital capacity, bedside forced vital capacity. And this is a must-to-do examination for any case of myasthenia gravis. To my experience, this is the simple thing, but candidates miss it most. Truly speaking, PACES exam is a very much doable exam. And the cases you are going to face at exam, they are not that much difficult. And candidates fail usually for making small mistakes, silly mistakes. It is not like that you are not going to get the diagnosis, you are going to make a very big mistake. This is not right at all. Any candidate who is going to fail the exam, fail this just by making simple mistake. So that's all. So our next part is A, that is association. So from the physical examination, we have to rule out other autoimmune association. The mnemonic, GAT, CPR, MB. So how to rule them out? We have to tell the examiner that we want to measure the bedside blood sugar. We have to tell that we want to measure the sitting and standing blood pressure to rule out postural hypotension, which is a symptom of Addison's disease. we have to tell the patient to take a sip of water and swallow it. It is just an acting. We have to show the examiner that we are ruling out thyroid swelling, which is a part of.
With dysphagia, doctor,
Sorry, doctor.
with the difficulty swelling, can do that?
No. Actually,
Okay.
in autoimmune thyroid disease, there can be thyromegaly. So whenever you are going to check the swallowing test, asking the patient take a sip of water, then coming at the level of the patient by bending and see the swelling, you're ruling out whether there is any thyroid swelling there, and this will give a signal to the
Okay.
examiner that candidate is ruling out thyroid association. This is just an acting, and truly speaking, in the real exam, you will never get thyroid swelling with a case of myasthenia gravis. This is 100% guarantee.
Okay. Thank you.
Most welcome, doctor. Then for the celiac disease, if from the history, the patient does not give any complaint of loose motion, we don't have to do any physical examination. To rule out the pernicious anemia, we just have to look at the conjunctival pallor and tongue, looking for glossitis. That's all. To rule out rheumatoid arthritis, if from the history, the patient does not give any complaint of joint pain, we don't have to examine any joint. Then the case is itself myasthenia gravis. To rule out vitiligo, we have to look at the hands and feet and tell the examiner that I want to examine the whole body skin, ruling out any hypopigmented skin rash. Examiner would get it, understand that you want to rule out vitiligo. So that is how from the physical examination, we can rule out, we can formulate the CCCA formula. Sounds clear, doctors? Any question from anyone?
No, sir. And should we offer gag reflex for oropharyngeal dysphagia?
No, doctor. No, never. Gag reflex, if you offer for gag reflex, you will not be allowed to do this. This will surely go against the welfare of the patient. That is why I have told that we cannot do any examination to confirm our diagnosis of oropharyngeal dysphagia. In oropharyngeal dysphagia, patient will have absent gag reflex. Got it, doctor?
Yes, sir.
Please tell me if you have any further confusion.
No, sir.
Okay, thank you. So we have covered the physical examination. Now let's come to the investigation part. So in the investigation, again, we are going to formulate the CCCA. That is confirm, cause, complication, and association. In the investigation, in the PACES exam, whenever you are going to mention any investigation for any case, always start with this line. This is very simple line, but missed by many candidates. I will not say most, it is missed by many candidates. The line is apart from basic investigation. This simple line. So apart from basic investigation, to confirm our diagnosis of oropharyngeal dysphagia, we have to do video fluoroscopic barium study. This is the investigation of choice for any oropharyngeal dysphagia. All of this necessary investigation and management, you are going to get it in separate recording section of this course. In this course, we are going to cover more than 240 real PACES cases with investigation, physical examination, and management recording for each of the cases separately. So this is the investigation to confirm the diagnosis of oropharyngeal dysphagia. Then to find out the cause. The cause is myasthenia gravis. So we have to do all the investigation to confirm the myasthenia gravis. There are some blood tests like anti-acetylcholine receptor antibody or anti-mask antibody if anti-acetylcholine receptor antibody comes negative. We can also do single fiber electromyography or repetitive nerve conduction study. also CT scan to rule out thymus. These are all the investigation to find out the cause of our oropharyngeal dysphagia. Then to rule out the complication, we have to do spirometry, ruling out breathing failure, and chest X-ray, ruling out aspiration pneumonia. To rule out the association, again, we have to remember that CPRMB. Whenever we are going to tell our investigation, we have to tell the examiner in this way. Like, apart from basic investigation, to confirm our diagnosis of oropharyngeal dysphagia, I want to do video fluoroscopic barium study. Then to find out the cause of our diagnosis, that is the myasthenia gravis, I will do this test. Then to rule out the complication, I will do the spirometry and chest X-ray. And to rule out other autoimmune association, I will do the fasting blood sugar and HbA1c, ruling out diabetes. I will do the 9 a.m. serum cortisol, ruling out adrenal failure. I will do the thyroid function test. I will do the celiac serology. I will do the, from the complete blood count, I will look for anemia. Then I will look for red cell folate and serum vitamin B12. To rule out rheumatoid arthritis, I will do anti-CCP and rheumatoid factor. And for vitiligo, I have to diagnose it clinically, not with any investigation. And in this way, if you are going to tell every investigation in this way, it will take almost 1 to 2 minutes. It will also kill your time, and examiner will become very happy that you are going to touch every important part. So let me know from the doctors whether this portion is clear to all. From the investigation, how to rule out the CCCA.
Yes, sir.
Should I proceed? Any question from any doctors?
No, sir.
Excuse me,
Proceed.
doctor.
Yes, doctor?
Excuse me.
Yes.
Should I request for all this investigation, even if there is no suspicion of Addison
Yes,
or
yes.
diabetes or
Yes.
Bernice? This is
Yes,
routine. When I come to any myasthenia gravis, I have to request all this investigation routine, and also in any case it will be like this. I request whether there is a suspicion of complication or not.
Yes, we can offer all that cases, but for all the cases, you will not get all the components of CCCA. In this course, we try to give a training to the candidate to think in this CCCA formula to see whether which case has which component or not. Hello? Dr. Miano, are you clear with your question?
Okay, thank you. Thank you.
You can ask for all the investigation, doctor. It is allowed. Okay. So this is how the CCCA formula is done. We have to do it from the history, for the physical examination, and from the investigation. Also in the management, we have to tell like this. In the management, for every management, we have to do the education and counseling, forming a multidisciplinary team. Then we have to tell the treatment of the underlying cause, treatment of the complication, and treatment of the association. All these things are given in detailed recording with a separate access to each of the type 1 and type 2 candidate. So why I have discussed this? There's a particular reason behind discussion of this topic. In the physical examination, if the examiner is happy with your sequences of physical examination, he is going to award you with satisfactory mark, that is 2 mark for physical examination. If he is borderline satisfied, he is going to give you 1 mark. If he is not satisfied at all, he is going to give you unsatisfactory with 0 mark at physical examination. And in this section, why he has given the 0 mark will be written in details. So in real life, there are 2 ways of doing the physical examination. Most of the cases, candidates start with doing the general examination first, starting with the hand, then looking for anemia, pallor, or jaundice, and something like that. This is one of the good way of doing the physical examination. But sometimes in the exam, you may miss important physical examination if you do with this sequence. like starting with general examination. But if you formulate inside your mind this CCCA formula for physical examination, then you are not going to miss any important part of the physical examination. Because one of the examiner will roam around you and see each of your physical examination, whether you are touching each component or not. Sounds clear to all the doctors? Any question from this physical examination section? In this whole course, for all of the 240 plus cases, we are giving a sequence of physical examination for all of the cases separately. Candidates has to make notes, revise them multiple times, then they have to practice with their partner, and at practice session for the active pen candidate, I will assess the homework individually with each active candidate. So this is for the physical examination. Our next skill is identifying.
I have a question,
Yes,
please.
Sure, doctor.
In case of examination for myasthenia gravis, the respiratory examination of the chest, should I go through all the steps by inspection, palpation, examining of the chest movement
No,
in
doctor.
details, or just
No.
auscultating and go?
Doctor, I have told this thing actually. Yes. There are two ways of doing the examination. Like you have told that we have to examine the respiratory system. If you do like this way, sometimes you are going to miss important part. Like there are certain ways how the myasthenia gravis case comes in the PACES exam, in the long clinical consultation. In the PACES exam, you will never be given with the prompt of breathlessness for a case of myasthenia gravis. I have never seen such case in last 4 years, and it will never come. How the myasthenia gravis case comes in the exam? One way it can come as a case of double vision. It can come as a case of dysphagia. It can come as a case of fatigue. And that's all I have seen. So whenever how the case comes, first we have to do the examination to confirm our diagnosis, then find out the cause. The cause is myasthenia gravis. So I suggest to each of the candidate to make it by mind, to memorize each of the steps of myasthenia gravis examination that is going to be provided by this course. Then they have to practice it at the bedside or on some dummy patient. This is how the way, before you have to train your mind beforehand. Then you can make it happen at the bedside. Am I being able to meet your consent, doctor?
I mean, I will not check every system
No.
by all steps here.
No, doctor. You cannot cover
I
all
will
the
consider
steps.
all physical signs associated with myasthenia gravis.
Yes, doctor. You have to be concise, and you have to make it before and inside your mind. If you want to touch all the system, then surely you will not get enough time. And the examiner will write in the feedback that he is not professional. He does not know what to examine. It will be written here.
Okay, thank you.
Okay. One of the doctors asked, what is CCCA? Okay, I'm telling it again. The CCCA is confirm the diagnosis, find out the cause or trigger, find out the complication, and last, ruling out association. All this CCCA has to be found and ruled out from the history taking, from the physical examination, and from the investigation. And this is one of the special characteristics of this course, where this whole course period, we train each candidate to rule out this pattern. So let's come back to the mark sheet again. So our next skill is identifying physical sign after the physical examination. In this identifying physical sign, one of the most important thing each candidate has to remember that in the PACES exam, omitting is better than committing. Why I'm telling this? I'm telling this because sign synthesis is a great crime in PACES exam. If you synthesize even one sign, you will get automatic 0 in this identifying physical sign. Please keep this in mind. This identifying physical sign again is divided into satisfactory, borderline, and unsatisfactory. In the PACES exam, two types of cases are given for both the station of LCC. One is acute case. One of the station, like station 2 or station 5, you are going to have an acute case. Another one is stable case. This is the pattern. One of the case will be acute, one of the case will be stable. In the acute case, in more than 95% of the cases, this will be dummy case. But for the stable one, this can be real patient. But it can be dummy also. Why I am telling this? There's a specific reason for that. In the dummy case, you are not going to get any positive physical finding that is going to that should go in favor of a diagnosis. Let me give an example. This is real example. One of the most common case of PACES exam is hematemesis. This is an acute case. We are going to discuss today the approach to hematosis. So you may be given a young kid or young medical student who has been just given there at the station to tell you that I'm having 5 to 6 episodes of blood vomiting from today morning. And the cause is found to have some peptic ulcer disease due to taking NSAID without PPI. This is a very simple case. At the same time, candidate make a lot of mistake in this simple diagnosis. So this is going to be the simple case. So anyone who is having 5 to 6 episodes of blood vomiting from today morning, surely going to have anemia. Isn't it, doctor, in your real life? But at the exam station, whenever you are going to look for conjunctival pallor for that young person, you will never get this anemia. But for the sake of your diagnosis, to match your diagnosis, if you tell the examiner that on physical examination, I have got anemia, then surely you are going to lose all the marks in identifying physical signs. So be very careful about your physical findings. This young medical student may be instructed to tell you to show some pain whenever you are going to palpate his tummy. That is also fake. But if you synthesize the anemia, because the patient is telling 5 to 6 episodes of blood vomiting, then you are going to surely lose the mark in identifying physical signs. May I know if this is clear to all? This is true for also for the real cases. In the real cases, suppose you have been given a case of systemic sclerosis. Systemic sclerosis patient has a lots of physical findings. You have been able to identify a lot of physical findings, but unfortunately, you mentioned loud P2. Only for mentioning loud P2, which was not there, you lost all the marking in identifying physical signs. Because sign synthesis is not a great, it is the biggest crime in PACES exam. You have to be 100% honest in identifying physical signs, and the candidate and the examiner is going to assess you for this. Any question from any doctors from this skill?
No, sir.
Okay. Dr. Rahul, are you clear, doctor? Dr. Mangalasi, are you clear?
Yes, sir. So I'm there, sir.
Okay.
It's clear to me. Yes, sir. Thank you.
Okay. Thank you, doctor. Now let's come to the next skill, that is the clinical communication skill. And this skill really needs a lot of stuff to do and a lot of hard work. In this whole course, we are going to train you for this skill. This skill actually assess how you are going to communicate with the patient clinically, how you are going to take the history, how you are going to rule out important differential diagnosis. All of these things will be assessed in this clinical communication skill. So let's start. So I'm going to enter into the history taking pattern right now. And this will comprise the clinical communication skill. So this is the flow chart, how the history should be taken. I'm going to give a written sheet to everyone, like what you have to ask for introduction, what you have to ask for symptom analysis. I'm going to discuss this in detail in this course, and all of the active type 1 and type 2 candidates is going to have this PDF with themselves. So don't worry. So after entering the station, first we have to do the introduction. Then we have to do the symptom analysis. Then systemic review. Then we have to cover this PDF, Sajid, PET, and 5P. What does this mean? I'm going to discuss it in details because this is going to be the best important part of this long clinical consultation. And this carries a lot of importance. There is a hidden trick there. Then we have to examine the patient and we have to meet the concern. Based on this examination, you will be given mark in this physical examination, and based on the meeting concern, you will be given mark in this skill, that is managing patient concern. So let's start. I think I should delete some page. That will be better. Pardon for my interruption. So how to do the introduction? After entering the station, you have to do the introduction like this. You have to use your surname. Like my name is Otonu De. So I will tell like this. Hello, I'm Dr. De. I'm one of the doctors working here today. We have to try to keep a smiley face that will show our professionalism, especially to the British doctor. Then we have to tell this line. That is, I am here to talk to you about your problem and examine you. Is that okay? If at any point you have a question, please feel free to interrupt me anytime. I may take a few notes during your conversation, but rest assured, everything remains confidential. All of these lines are important because confidentiality is a big issue for United Kingdom. We are going to carry a piece of paper with us, so the patient might think that my confidentiality can be breached. So we have to make assured of the patient that whatever note, whatever thing we are going to take from you, this will remain confidential. Truly speaking, these are just acting, and we have to do the acting in front of the examiner to show our professionalism. Then we have to ask, so in your own words, could you please tell me what brings you here today? So what brings you here today? This is an open question. We have to avoid asking closed question. Like if the prompt is swallowing difficulty, we should avoid asking, can you tell me about your swallowing difficulty? Because most of the time, if you ask this open question, surrogate or the patient is going to give you a lot of information. So let him give the information. Why to stop him? If you ask him, tell me more about your swallowing difficulty, then he or she is not going to give you anything else the swallowing difficulty. So better asking this open question. So again, I'm starting from the beginning. Hello, sir, I'm Dr. De, one of the doctors working here today. I am here with you about you. I am here to talk to you about your problem and examine you. Is that okay? If at any point, if you have a question, please feel free to interrupt me anytime. I may take a few notes during our conversation, but rest assured, everything will remain confidential. So in your own words, could you please tell me what brings you here today? So this is the introductory section.
Sir,
Yes, doctor.
aren't we going to ask their name and age in introduction? Confirm
Yeah.
his name and age.
You can ask it, or you can also avoid it. It is not that much essential. Okay, better to ask it. Sorry, it was missed here. Better to ask his name. Yeah, you have covered an important point. Ask his name and age. Thank you, doctor. We have to identify we have to confirm the identity of the patient. It has to be covered. Thank you for adding this, doctor. Any other questions?
No, sir. Thank you.
Okay. I'd like to tell to the participant that regarding the course details, everyone who is added to the group, please ask this separately after this session. You can also knock me at my WhatsApp. I'm going to give you the details of the course. This is a little bit different from other courses, so everything is going to be different. You may have confusion what is type 1, type 2, and all other steps. I'm going to describe it in detail to you. So let's just focus on the course. So this is how the introduction is done. Then we have to do the symptom analysis. If we look at the flowchart, our next part is symptom analysis. And there's a certain mnemonic. The mnemonic is ODPARA. This is my personal mnemonic. You can use any one of your want. Here, O goes for onset, D goes for duration, I goes for initial episode, P goes for progression, A goes for aggravating factors, R goes for relieving factors, and A goes for associated features. So what goes for O? O means onset, that how did it start, suddenly or gradually. D goes for duration. We have to ask for how long you are having this symptom. Sometimes you may be given a symptom which is there for a long period of time. This kind of thing happened in last year at Kochi Center. There, a young patient was given, the complaint was headache. And he was telling that I am having headache for the last 5 years. So does it make sense that the patient is suffering from headache for this last 5 years and he is going to come right now? What is the reason for coming right now? There must be any change in the pattern of the headache. So whenever the symptom is long term, we have to ask whether there is any recent change of pattern of the symptom. This is very much important. If you don't ask in this way, most of the time, the surrogate will not give you the information. He will just move you make around that 5-year headache that mostly can be the diagnosis could be tension headache or migraine headache. But if there is, in that case of Kochi, there is a recent change in the pattern of the headache, and recently the pattern has changed in the form of increasing the headache with coughing, sneezing, and bending forward. So it is a new onset brain tumor. Earlier headache was due to migraine, but recently the pattern has been changed. May I know to each candidate if it is clear to all about the duration? Okay. Then I goes for initial episode. We have to ask, is it the first time or have you had this type of symptom before? P goes for progression. We have to ask, is it gradually increasing day by day? Then A goes for aggravating factor. We have to ask, anything increase your symptom? R goes for relieving factor. We have to ask, anything improves your symptom? And A goes for associated features. We can ask, is there any other associated feature you want to mention with this? Most of the time, the surrogate will never tell you anything unless you ask specifically. So here goes for ODPARA. Any question from this?
No,
Using this ODPARA, we can analyze a lot of prompt, but not all. Whenever any prompt cannot be analyzed with this ODPARA, what are the specific sets of questions in this course I'm going to provide you separately. We are going to discuss it in the prompt session. Then there is different mnemonic for the pain. My personal mnemonic is liquor. It's a type of alcoholic drink. You can use Socrates or whatever you like. Here, liquor means L for location, I for intensity, Q for quality, and R for radiation. In the PACES exam, if anyone tells or complains of any pain, always look at the site, identify the location. Let me tell you why it is important by some real PACES example. At one time, a case at Pondicherry came. From outside, the prompt was low back pain. So many candidates thought that this is a case of musculoskeletal pain. But the wonderful candidate were smart enough, they asked, can you please show me the site of the pain? And whenever they offered that, the patient shows the renal angle. That is also the back. So basically, it was a case of pyelonephritis. The cause was due to taking SGLT2 inhibitor. Therefore, asking for the location, to identify the location, is very much important for every kind of pain. I am repeating again, whenever you are going to get any case of pain in the PACES exam, always ask for location. Please ask the candidate surrogate or the patient, can you please show me the site of the pain? Sometimes this will make a lot of difference in the diagnosis. Then I goes for intensity. We have to ask how severe it is on a scale, 1 being the lowest and 10 being the highest. Then Q goes for quality. We have to ask what sort of pain is it? Can you describe it for me? Is it dull? Is it cramping? Is it boring pain? So you have the patient is going to describe the pain for me. Then R goes for radiation. We have to ask, after starting from here, does it go anywhere else? And regarding pain, always offer help with painkiller. If the pain is on the scale of 1 to 10, if the pain is more than 6, you have to offer painkiller. I will suggest for any kind of pain, ask the patient, do you need any painkiller? Because we have to manage the patient, we have to prove our professionalism towards the examiner. To prove it, we have to offer this painkiller. Please don't forget this point, because these small things carry mark in the PACES exam, especially for the clinical communication skill. If the pain is severe enough and you are not going to give any painkiller to the patient, the examiner is going to mark that point, and he is going to surely cut the mark in the clinical communication skill. So sounds clear, doctor? How the symptom analysis can be done? Any question from any doctors?
No, sir.
Okay, thank you, doctors. So in our flowchart, we have covered the introduction. Then we have done the symptom analysis. We can use the mnemonic ODPARA or LICOR. And there are some prompts which cannot be analyzed by ODPARA or LICOR. For that specific prompts, I'm going to give you the specific sets of symptom analysis questions. Then we can jump into the systemic review. For the systemic review, we can cover all the systemic questions, starting from the general review, then CNS, cardiac, respiratory, gastrointestinal, renal, all these things we can cover. This is the usual way that most of the candidate is going to do. But I will suggest you something more than that. What is that? The trick is, after doing the symptom analysis, if you directly jump into the PDF. Sorry, what is PDF, Sajid? Let me tell you. So PDF means past medical history, drug history, and family history. Sajid means smoking, alcohol, job, impact on job and daily life, and driving. Each of the point is very much important, because if you miss any of the point, then surely mark is going to be cut, and each of the point has to be touched, because such you have forgotten to ask how the symptoms is impacting his job and daily life. Then surely the mark is going to be cut, because this goes against professionalism. Then goes for PET. PET has not to be taken for every prompt. PET has to be taken for cough, diarrhea, fever, and joint pain. Here P goes for PET. E goes for exposure, that is casual sexual exposure. And T goes for travel history. Why this is important? One of the case earlier came, the prompt was cough. and the patient was a pigeon lover. Can you spot the diagnosis? Any candidate?
Hypersensitive pneumonitis.
pneumonitis.
Yes, doctor. Like this way, for cough, diarrhea, fever, and joint pain, this pet history, casual sexual exposure, and travel history are very much important. Excuse me. This PET has to be taken only for these 4 prompts. Otherwise, it is not needed. Then come to the 5P. 5P has to be taken for every female of reproductive age. Here 5P goes for pill, period, pregnancy, abortion, that is abortion, and partner. It has to be taken for every reproductive age female group. So let's come to the trick again. The trick is, sometimes you may find yourself in difficult to get into the right diagnosis. But after doing the introduction and symptom analysis, if you directly jump into the PDF, that is the past medical history, drug history, and family history, it is my guarantee that in more than 80% of the cases, you'll get your diagnosis. This is 100% guaranteed, and this is a hidden trick. But you have to know in particular what question you have to ask for the past medical history, what question you have to ask for the drug history, what question you have to ask for the family history. Like in the past medical history, you have to ask these 8 sets of questions. You have to memorize it by heart, because in the exam, you just have to reproduce these questions. That do you have any past medical condition that I should be aware of, any surgery before? Because if you ask about any past medical condition I should be aware of, the surrogate will never give you the answer that he had surgery before. Okay, let me give some example, real PACES cases. Then you will get the idea. Now I'm going to give you some real PACES cases example, how PDF can save you in PACES long clinical consultation. 3 years back at Bangalore, a case came. The case was fever. The prompt was fever. It was a 45-year-old male. I talked personally to the candidate who appeared at this exam. He told me that he was not getting any clue what can be the diagnosis. He asked, "What do you have any past medical condition I should be aware of? Any surgery before? Any blood transfusion before? Any family history?" All the systemic questions, but no clue came out. So right before the ending of the history taking, whenever there was about 2 minutes left, he asked this question. That is, any recent procedure? Then the patient replied, yes, 1.5 months back, I had a dental procedure and the fever was there for 1 month. No other past medical history. So based on this history of recent dental procedure, can you guess the diagnosis right now?
Infective endocarditis.
Yes, doctor, infective endocarditis. And he described his feelings that after asking this question, he got his diagnosis. And the patient was a dummy case. He was not having any positive physical findings.
Any murmur or anything?
Nothing was there. Absolutely normal patient.
Only fever and dental procedure. That's
yes, only fever and dental procedure. Sometimes he may be given a case of history of mitral valve replacement, but real infective endocarditis patient is never given in the PACES exam because this is a toxic patient. This patient is not stable, and they are not going to put this patient in the PACES exam. They are going to give the patient who are stable. And sometimes some patient may find difficulty with the candidate. They will surely change the patient. So infective endocarditis, is truly speaking, is not a PACES case. They are going to synthesize the case, but with not real infective endocarditis patient. So again, if you synthesize the regurgitant murmur for this case, you are surely going to lose the mark in the identifying physical signs. This is real
any chest pain or any racing pacing of heart, anything like cardiovascular system?
Yes. He mentioned this, but whenever you are going to feel the pulse, you will not get the tachycardia there. He's going to complain you that I feel some racing pacing of heart, I feel some fever. But whenever you are going to touch the patient body, you will not feel any high temperature. This is how the PACES exam runs. Is it clear, doctor? Let me give you another example. This case has come multiple times. In this diet, I'm going to give you the example, the prompt I'm going to discuss. In this diet, this has come at 3 centers. And this is going to be repeated at every diet. The prompt is tingling and numbness. Sometimes the prompt can be given as paresthesia. So you have to analyze the tingling and numbness. I will guide you how to analyze. But the clue is, in the past medical history, the patient had thyroid surgery.
That's hypocalcemia.
Okay, let me complete it, doctor. In the drug history, in Diet 3 Dhaka Center, they add the drug bisphosphonate. So based on this, first let me know what is the diagnosis. She was also having some perioral numbness.
Hypercalcemia.
Sorry,
Hypercalcemia.
Hydrogenic, hypocalcemia. Yes.
Hypocalcemia. It can be due to hypoparathyroidism due to thyroid surgery, or can be due to bisphosphonate.
Bisphosphonate, yes.
Yes. That is why past medical history, drug history, and family history is very much important. Let me give you another more example. Then you will get more convinced. Right now, I'm going to give you my real personal example. The case I got at my time. One of my case was headache. From outside, the prompt was a 35-year-old male has come with headache. In the vitals, the temperature was given higher. It was something like 39 degrees Celsius. After entering the station, the patient was wearing a gown, a completely normal patient who was looking at me with happy face. So I asked him all the questions of headache, odipara, something like that. In the past medical history, I asked him, do you have any past medical condition I should be aware of? He completely denied. Then I asked him, any surgery before? Right after that, he replied that 5 years before, I had a road traffic accident, and after that, I had some surgery of my tummy. Just this line. And he was wearing the gown. I just removed the gown. After taking his permission, that can I see your tummy? I saw that it was a splenectomy scar. He even did not tell me what is the name of the operation. He just told me I'm not aware of the name. What I got, it was a splenectomy scar. So any patient coming with headache with splenectomy scar, before going to the diagnosis, can you tell me what 2 important questions we have to ask after that?
Vaccination history and vaccination and antibiotic prophylaxis.
Wonderful answer, doctor. Simply wonderful. I just asked him about the vaccination, that did you take the recommended shots? The non-jargon term of vaccination is shots. He replied that he lives in a slum, he drives car, that's why he could not afford to take the shots. Then I also asked him, did you take the recommended antibiotic? He denied that due to the financial difficulty, I cannot take this. After that,
sorry, why he could not get the shots?
Because of financial problem.
Oh, okay.
That is another hidden issue. So I have to arrange the vaccination and antibiotic for the patient. So I have to refer the patient to the social worker to get some financial help. I did this. That for this, I'm going to refer you to the social worker after our consultation today. So all of you have guessed what is the diagnosis here? What is the diagnosis? Can you know it?
Meningitis.
Yes, meningitis. Meningococcal. Sorry, not meningococcal, pneumococcal. So that was the case there. I got full mark at both LCC just by asking this question, and the PDF saved me. Let me give you another example. All of these are real PACES cases.
They are very interesting examples.
Yes, doctor, these are real cases example. And if you talk to any candidate who has appeared at the exam, you can surely get this. There is a popular case also that is a 55-year-old female has come with low back pain. Vitals are given, vitals are normal. But after entering the station, you are going to analyze the low back pain. I'm going to give you the detailed analytic question. What was found there? In the past medical history, the patient had breast cancer, which was treated with surgery and chemotherapy. It was like 10 years back. So only this question is enough, only this answer is enough to get your diagnosis. Any volunteer?
Final cord compression.
Due to?
Metastasis.
Yes,
Patient is
metastasis.
getting steroid for immunosuppression.
He's not getting any steroid right now. That is another
Bony
question.
metastasis.
It's a bony metastasis. Surely in the concern, the patient is going to ask you, I was declared cured. Why I'm having metastasis right now? And you have to meet the concern. Let me give you another example for the steroid. The case is again the same, a 45-year-old female with low back pain. This case has come in the PACES exam. In the past medical history, the patient is having bronchial asthma. And in the drug history, she has been taking steroid for the last 4 months because 4 months back, she had an exacerbation. And she has not stopped after that without visiting the doctor. So what can the diagnosis here?
Osteoporosis due to steroid.
Osteoporosis leading to the
Yes, doctor.
osteoporotic fracture.
Osteoporotic fracture. It can be fracture or it can be simple osteoporosis. Wonderful diagnosis, doctor. That's why I tell that if you know the tricks, LCC or long clinical consultation is very easy to pass. You have to know the right approach, then you have to do a lot of practice. Only by knowing this, you are not going to get the full mark. And if you can score full marks at both the long clinical consultation, you will get more closer to the passing the exam. Because these 2 stations, candidate face a lot of difficulty. And I personally faced myself during my preparation period, a lot of hazard, a lot of difficulties for this station. So this is...
Excuse me, doctor.
Yes, doctor.
This is, when I asking a question about past medical history, I should specify any disease or just I ask general question so the surrogate will not answer?
Yes, if you ask general question, the surrogate will not answer. They are given...
So I have to specify.
Yes, you have to ask these specific questions. Like, let me give an example. All of the cases, you are going to get it as type 1 and type 2 in written format PDF session. These are real PACES cases. There you will get a case. The case is low back pain. So it was a 60-year-old male with low back pain, and he had a history of recent injury to the leg while gardening. In the past medical history, he was also having diabetes. So what can be a diagnosis for that? Can anyone guess?
Discitis.
Yes, doctor. Discitis. Unless you ask about this line, any recent injury, the surrogate or the patient will never give you the answer. This is guaranteed. They are given instruction. There is a case, knee pain. You are going to get a sole in knee. This case is also there, and this is real PACES case. It is a 65-year-old male. Okay, Dr. Shweta has asked, it was a discitis, doctor. We discussed it as a discitis. So for the knee pain, whenever asking the past medical history, the patient replied that he had some wearing and tearing of the knee joint. But whenever you are going to ask any recent procedure, then she is going to reply you that 5 days back, he had some steroid injection into her knee joint. And for the last 3 days, she is having swelling of the knee joint with fever. So what comes the diagnosis, doctor?
Septic
arthritis.
Yes, doctor, wonderful diagnosis. That is why you have to know each question. You have to get it memorized beforehand. Because in the exam, you just have to reproduce these sets of questions for the past medical history, for the drug history, and for the family history. Okay, Dr. Shahab had raised a hand. May I know what is the question, doctor?
Yes, do I need to specifically ask, like, do you have any history of diabetes, high blood sugar, high cholesterol?
No.
Do I need to specify those things?
No, doctor. If you ask, do you have any past medical condition I should be aware of? This question will alone cover the diabetes, high blood pressure, dyslipidemia, heart attack, or brain stroke. But it will not cover the surgery.
Okay. Okay,
Sounds
doctor,
clear?
thank you.
Okay, most welcome, doctor. Okay, let me give you some more examples. All of these cases are there in the PDF section. You will get it. There is a very much popular case. This case again comes every diet. This is a case of breathlessness with dry cough. This is a middle-aged female, like 40 years female. In the past medical history, she is a diagnosed case of rheumatoid arthritis. In the drug history, she is taking methotrexate. So you can easily guess the diagnosis here. What is the diagnosis?
Pulmonary fibrosis.
ILD.
ILD due to?
Due to RA itself or due to methotrexate?
Yes, doctor. RA or methotrexate, both can be the culprit. It will be decided by the rheumatologist, not by myself. In the PACES exam, also we have to know up to what level we have to perform. Okay, I have to discuss this important issue. Actually, by PACES exam, we are assessed to enter into the ST3 level. That is the register level there. After ST3 level, you are going to you are going to receive training for ST3, 4, 5, 6, 7, and 8. Right after that, you are going to be declared as a consultant. So they are going to assess you whether you are suitable enough, whether you are professional enough to perform at the ST3 level. They are not going to assess you as a consultant. That is why it is not needed to know a lot of theoretical question or theoretical answer to pass this exam. And all of you who have already appeared the exam, you will be able to see that right before entering the exam, the British examiner come and tell this briefing that don't panic. This is a very easy to go exam, and we are going to give the cases that you face in your day-to-day life. All of these stuffs are going to be told because they want to tell you that we are not going to assess you as a consultant. We are going to assess you as a registered level there. Sounds good, doctor?
Yes, sir.
Okay. So in this way, past medical history, drug history, and family history is very much important. And right after the symptom analysis, if you jump into the PDF, in more than 80% of the cases, you will get your diagnosis. This is my guarantee. Sometimes you can get both the cases common, both the cases diagnosis. Also, you have to know what questions specifically you have to ask for under each section. Like in the past medical history, you have to memorize these 8 sets of questions. For the drug history, also you have to memorize these 8 questions. And the most important question among these, for which the candidate sometimes make mistake, is the medication allergy. Has it been missed here? I'm sorry, it has been. This is the medication allergy.
5 number, it's there. Yeah.
Oh, sorry. So yeah, it's 5 number.
Allergic to any medicine.
Yeah. Sorry, doctor. Like the introduction, confirmed the identity, I thought it was missed. Yes, this question is very much important. Because if you talk to any British doctor, you will get to understand that allergy to any medicine is very much sensitive to them. Sometimes you can get this information which has nothing to do with the real diagnosis. Let me give you some real example. A dietary at the center, a case came with loose motion. The candidate who appeared at my course, I talked to him personally. In my course, I repeatedly give training to every candidate to ask this question: that do you have an allergy to any medication? The diagnosis of that loose motion was infection and malignancy. But he asked whether there was any allergy to any medication. After asking this question, the surrogate replied, 5 years back, during an episode of respiratory tract infection, he was given penicillin and he had an allergic reaction to that. And he was the only candidate at his diet or at his carousel who got this information. Whoever did not ask this question missed the information, and this is surely going to affect the clinical communication skill mark. So allergy to any medication is very much important, and never forget to ask this. And also, if you don't ask whether there is any recent introduction or withdrawal of any medication, the surrogate is not going to give you the answer. Like in this diet at Pondicherry, a case came that was a loose motion. The candidate who appeared at this exam, he was also a candidate, participant of this course. So she asked whether there was any recent introduction or withdrawal of any medication. The surrogate replied, recently he took some antibiotic. So can you guess the diagnosis right now?
Pseudomembranous colitis.
Yes, doctor, pseudomembranous colitis. So unless you ask this question, the surrogate is not going to give you the answer. So my suggestion is better to memorize all the questions. Okay. I think some sound is coming there. Okay. Then come to the family history. In the family history, we have to ask any disease running in the family. Then any one of the family members having similar problem. Then for the syncope and palpitation, we have to ask this question. That is any family history of sudden death. It is only for the syncope and palpitation prompt, not for other cases. It is not necessary. For the goiter, and where you can suspect the multiple endocrine neoplasia, you have to ask this question. Any family history of gland cancer. You will get this case and approach accordingly in this course. Then for all the GIT prompts, you have to ask this question must. That is any family history of bowel cancer. So this is all for family history. And this comprises the past medical history, drug history, and family history, which I will suggest the most important, easy, and tricky part of the long clinical consultation. May I know if there is any question from any of the candidate?
No, sir.
Okay. Then Sajid goes for smoking, alcohol, job, impact on daily life, and driving. So my suggestion is, for the PACES exam, first do the introduction, then do the symptom analysis, then complete the PDF and Sajid. If the female is in reproductive age, also touch the spike P, touch the PEG if it is needed. Then right after that, come to the differential diagnosis screening question. And how to do the differential diagnosis screening question, we are going to have in detailed discussion in our prompt session. Right after that, we have to do the examination, and at last do the meeting the consent. And especially sometimes the patient may have a lot of concern. They may carry a paper with them, and you may find at best 5 consent written there. So you will get 15 minutes in total to perform all of this. And after 13 minutes, you will get a signal that you have 2 minutes left. My suggestion is complete up to this examination part within this 13 minutes and keep 2 minutes at hand to meet the consent. Otherwise, you may not be able to meet all the concerns. It is very much easy. Once you perform a repeated amount of time, it is easy to perform, and this time will get set inside your mind. You'll not have to look at the watch multiple times. It sounds like some biological clocks develops inside our mind when you do repeated practice. But only practice is needed after you get the right approach. So in this way, the history is taken, and this comprises the clinical communication skill. All these PDF Sajid, symptom analysis, ruling out a differential diagnosis. And this portion takes a lot of steps to do, and during the preparation, also during the examination. So may I know from the candidates whether anyone have any kind of question? Yes, one of the...
Can you show us the slide of Sajid, like how we should ask those questions?
For the Sajid, smoking, just we have to ask, may I know, do you smoke? Then for the alcohol, you have to ask, do you drink? Okay, let me discuss something interesting for that. For the smoking, we have to ask, do you smoke? If the patient replies, yes, I smoke, then we have to ask, how much for how long? Surely he is going to give you some definitive amount for a definitive period of time. Then for the alcohol, pardon for my mistake that I skipped this part of Sajid. For the alcohol, we have to ask, do you drink alcohol? If the patient say yes, our next question is it within social limit? The social limit is within 15 units in a week. If the patient replies, yes, I drink, but it is within social limit, then never dare to tell the patient to stop alcohol for the PACES exam, because it is... Yes, doctor? Okay. In the PACES exam, unless needed, never tell the patient to stop the alcohol if it is within social limit. But if it is affecting the liver, like the patient is having hepatitis, at that case, you have to tell him to stop the alcohol. Unless if he is drinking within social limit, never dare to tell him to stop the alcohol, because this will be counted as unprofessional by the British doctor. Is it clear, doctor? Any question from this alcohol portion?
No.
I expect
if there is any drug interaction with alcohol.
Yeah.
If there is any drug interaction with alcohol, should we ask to cut down?
Actually, drug interaction with alcohol happens in case of binge drinking. I expected this question, doctor. Thank you. In case of binge drinking, drug interaction happen. But if the drinking is within social limit, drug interaction is not likely to happen for the equal perspective. So whenever the patient replies, I drink within social limit, our next question should be, do you binge or not? Is it clear?
Even in alcohol-induced liver disease?
Yes. Whenever the liver is affected, we have to tell him to stop the alcohol. Like you may get a case of CLD presenting with hematemesis. For that person, we have to stop the alcohol. So I'm telling, if the liver is affected for any disease, then we have to tell him to stop the alcohol. Otherwise, not.
Or if he has dilated cardiomyopathy, then?
Actually, dilated cardiomyopathy case has not come up to now anytime in the PACES exam. This is truly speaking not a PACES case. And one of the characteristics of this course is that we are going to give you the idea what cases come in the PACES exam. Actually, in the real life, in your hospital, we can see a lot of cases, but they are actually not PACES cases for the long clinical consultation.
And
so this is... Yes, doctor?
If he's diabetic and he has dyslipidemia, then also, suppose he's obese, diabetic, then also...
Not needed. Unless the liver is affected, you don't have to stop the alcohol if he is taking within social limit.
Okay.
Please keep this important point in mind.
Lisa, can you give me here?
Yes, doctor.
The stethoscope and I put it in the case.
Okay. So if the patient, suppose if the patient tells you that I drink beyond social limit, that is more than 15 units, then you have to ask the CAGE questionnaire. What are the CAGE questionnaire? This is also covered in this PDF. The CAGE questionnaire is CAGE. C goes for cut down. That we have to ask, have you ever felt you should cut down on your drinking? And A goes for annoyed. Have people annoyed you by criticizing your drinking? G goes for guilt. Have you ever felt guilt about your drinking? And I goes for eye opener. Have you ever had a drink first thing in the morning to steady your nerves or get rid of hangover? That is, he needs a glass of wine every day in the morning to feel fresh. Otherwise, he cannot start his day. So this is the case questionnaire. And if you get anything positive in the case questionnaire, you have to offer professional help to the patient. You have to refer him to the respective department. Someone says this is an anonymous clinic, but for the PACES exam, if anytime you forget about any department name, you can just mention, I will refer you to the respective department. It is not necessary that you have to specifically remember the name of the department. You can just mention, I would like to refer you to the respective department for professional help to help you cut down your alcohol. Is it clear to all regarding the alcohol? Any question from any doctors?
Clear.
Okay.
Sir, what question you asked for regarding travel history?
Travel, yeah, I'm going to discuss it also. It is also covered in this PDF. I'm going to discuss it, doctor. Just wait
Thank
for
you,
a while. Okay, then we have to ask about job. If you miss to ask about the job, then surely you are going to lose mark in clinical communication skill. You have to ask, may I know what do you do for your living? Then we have to assess the impaction of the given prompt on his job and daily life. And in this part, if he needs any kind of support, we have to offer that. Let me give you an example. Suppose he has come to you with 3 days of loose motion and he works as a banker. So due to this loose motion, he is unable to attend the bank. So you have to provide him with sick leave. Suppose you have been given a case of hand tremor or recurrent fall, and the diagnosis came out to be Parkinson's disease. And due to this tremor and recurrent fall, he is unable to take care of himself. So it is affecting his daily life. So you have to refer this patient to the occupational health worker. This occupational health worker is going to come to his home, assess his home environment, and make any necessary change in his home environment to help him in his daily life. Sometimes they come daily to help him in his daily life. So
that is occupational therapist.
It's an occupational health worker, doctor.
Occupational health worker is like a doctor. He will do.
No, he's not doctor. He's not a doctor.
Okay.
It is named occupational, but he is going to help in day-to-day activities. It is provided also to the stroke patient who is having hemiparesis. So in the UK, they are going to change the staircase of his home. This is termed occupational health worker. This is not occupational therapist. Therapist is going to give therapy, that is physiotherapy. But this occupational health worker gives support to the home, personalized care. Is it clear, doctor?
Okay.
And sometimes he may need some financial help, like my case I discussed. For that case, we have to refer to the social worker. So social worker will provide money, and occupational health worker will provide support for day-to-day activities. So all of these things have to be assessed clearly by asking this question. That is how this symptom is affecting your job and daily life. Clear to all doctors? May I know?
Yes, clear.
Okay. The last part is driving. In the driving, actually, for passing the long clinical consultation, we don't have to memorize the DVLA rule because there is separate department in the UK named the DVLA who can deal with it. If we think that this symptom can affect his driving, we just have to tell stop driving and I'm going to refer you to the respective department. Sometimes you may find yourself memorizing the DBLA rules that for hypoglycemia, for how long you cannot drive. Even if the patient asks you that how long I cannot drive, you can just tell him that for this answer, I'm going to refer you to the DBLA route, the DBLA department. The department is going to give you the right answer. It is not necessary to memorize the DBLA rules. I'm again telling you. And sometimes you may become confused that whether you have to stop the driving or not. In that case, there is a specific way how you can save your back. The way is that in the UK, you will also always get help from the seniors for passing the long clinical consultation actually. So you can just tell the surrogate that stop driving till further assessment.
In every case?
Yes, in every case you can add this line. Like you are standing in the middle ground. You are not telling the patient to drive or not to drive. You are telling the patient stop driving till further assessment in this period, because in the long clinical consultation you are going to take the history. After that you are going to order a lot of investigation. Once the investigation comes, you are going to sit with the patient again. So you can just save your back by telling stop driving till further assessment.
So we can say this in the case of dysphagia as well?
Yes,
there is
doctor.
No
if you think you are confused about whether you don't know whether to stop driving or not, in confused cases you can use this line, that stop driving till further assessment, or till we get the sort of out of your problem. You will get full mark. Any question, doctor?
No.
Okay, Dr. Shabab has asked, in which case we need to urgently stop the drive. You will get it understand whenever we are going to discuss the prompt, like whenever there is double vision, which is going to affect the driving, you can tell stop driving. It is not necessary that you have to tell stop driving urgently. You just have to tell stop driving. Or you can save your back. You can take some safe approach like stop driving till further assessment. This line you can add to every case. Let me give you some practical example during my time, how this kind of approach saved me. In the communication station, I got a case of medical error. The case was insulin overdose. So I was asked that whenever the patient told me that it was a surrogate, that whenever I used to take the insulin with myself at my home, this thing never happened. So give me permission to take insulin of my own at your hospital. So I'm not working at the UK. So I am not aware of the rules there. So I just told him, regarding this question, I don't know the right answer right now. But I'm going to talk to my senior and I'm going to get back to you as soon as possible once the meeting stops, before you leave the room. So in this way, I just prove that I'm a safe doctor and I'm not a false doctor, like I'm not a dangerous doctor. Anytime in the UK, you need any kind of help, you can take help from anyone, in the form of internet search or in the form of talking to any senior, talking to any department. Whenever the feedback came, I got full mark. Is it clear, doctor? Any question?
Yes, sir, clear.
Okay. So this is for driving. Then for the PATE, for the cough, diarrhea, fever, joint pain, you can ask, do you have any PATE, any case of sexual contact? Then travel history. Regarding the travel history, you have to divide this into 3 sections. That is before, during, and after. Regarding before, you have to ask, did you take any preventive medicine? Like whenever you are going to travel to certain parts of the world, like the hilly region, you can take some preventive medicine to prevent malaria. During the travel, we have to ask for how long you stayed there. Where did you stay? Hotel or camp? Sorry. During your stay, I'm sorry to ask you some personal questions. These are personal questions, and before asking these sets of questions, like period or any sexual contact, we have to utter this line that I am sorry to ask you this personal question. That is, any unprotected sexual contact, any contact with cattle or sheep there for brucellosis, any contact with sick patient there for tuberculosis, any insect bite, any contact with swimming pool. Then after travel, did you continue primitive medicine after coming back? These 3 sets of questions has to be asked for travel history. I think one of the doctor asked this travel history. May I know, did you get your answer, doctor?
Yes, sir.
Okay. So we have covered the history taking completely. So in this way, we have covered the clinical communication skill. Again, this takes a lot of practice and lot of stuffs to do to get full mark in this clinical communication skill section. Even if you do touch all the section and perform properly, you will get satisfactory and get 2 marks from each examiner, not more than 2. Is it clear to all doctors? Any question from this clinical communication skill? Should I proceed forward? Session is getting bored.
Yes, sir, you can proceed.
Okay. The next skill is differential diagnosis. In the differential diagnosis, you have to mention at least 2 to 3 differential diagnoses. So what are the differential diagnoses you can mention? In this course, for each given prompt, we are going to give you a sets of differential diagnoses. Sometimes we'll give you some mnemonic to remember the differential diagnosis. And by using them here, you can easily get full mark in differential diagnosis section. In the differential diagnosis, usually they are not bothered enough whether you tell one before the another for most of the case, but except for one particular case. And I'm telling it based on my personal experience. That is for the mighty prompt of chest pain. Believe me or not, in the PACES exam, whenever you will get chest pain, for all of the world, in more than 80% of the cases, for the prompt of chest pain, it will be due to pulmonary embolism. You can match my word. And for this pulmonary embolism, if it comes as a differential diagnosis, you have to tell it as first D. If you mention it as 2 or T, number 2 or number 3, you are surely going to lose your mark. And I'm telling it based on my personal experience. I passed the PACES exam for my second attempt. During my first attempt, I attended at Bangalore. At the Bangalore, I got a case. She was a 45-year-old lady. She was working as a nurse there. Not 45, she was a 35. She was telling that, she was 48 years. She was telling that she was a diagnosed case of COPD, and due to a recent exacerbation, she was admitted to hospital for the last 3 days. She was about to get discharged, but right before discharging, she had some chest pain. She was absolutely normal. She was just laughing at me and giving me the answer. So
Why she was admitted for 3 days?
Due to the recent COPD exacerbation.
Okay.
It was due to pulmonary embolism, due to the immobilization.
Yes. So I mentioned pulmonary embolism as number 2. My first DD, I gave pneumothorax.
Pneumothorax?
Yes. I gave pneumothorax, and third DD was acute coronary syndrome. So what I got, one examiner gave me borderline in differential diagnosis, and another examiner gave me unsatisfactory. This is true.
What they write in the comment section?
They comment that pulmonary embolism should be considered first. And if you, later on I talk to many UK doctors, and if you personally talk to any UK doctors, you will get it that pulmonary embolism and deep vein thrombosis is very much common there. And they are very much sensitive to this. Whenever they get any case there on basis of suspicion, they directly go to the CTPA. I missed my pass mark only for 1 mark at that time in the DD. And surprisingly, the examiner who gave me unsatisfactory was showing a thumbs up reaction whenever I was going outside. He was showing such a way that I have made a very good. So this is how the PACES exam runs. You will not understand anything by the reaction. I thought that I had a very good exam. But whenever the feedback came, I saw that that guy gave me unsatisfactory. So I'm again suggesting be sure of the chest pain.
Sir,
yes, doctor?
You passed the differential diagnosis skill or not?
No. I failed for differential diagnosis only by 1 mark. Even I was given borderline by that guy, by that examiner. Pardon for my mistake. Then I could pass the exam for my first attempt.
If one of them have given you borderline, if the other one have given you borderline, you would have passed.
Yes, doctor. One gave me borderline, another one gave me unsatisfactory. Later on, I searched for a lot of cases, and I saw that for the chest pain for the PACES exam, the most important one is pulmonary embolism. So I suggest everyone that don't make this mistake which I made during my time. And how to rule out pulmonary embolism? There are 9 clotting questions. All the 9 clotting questions you are going to get in this course during the discussion of the cardiology prompt. How to rule out the pulmonary embolism by asking this 9 clotting questions. So this is all for differential diagnosis. Any question from any doctors?
No, sir.
Okay.
Sometimes there is only one diagnosis.
Yeah, sometimes there is only one diagnosis. They will consider for that.
And we will tell differential of the symptom, not of the main diagnosis.
You will get an idea based on the prompt. And okay, you have given a good question.
Like a case of Marfan syndrome and there is chest pain.
Yeah, I have got a question, doctor. What you are asking? There's an important trick for that. And this course will help you in this sense. Like, let me give an example. Suppose in this course, you will get a lot of mnemonic for each given prompt. Let me give you the chest pain. The most important one is pulmonary embolism. It can be due to aortic dissection. It can be due to acute coronary syndrome. It can be due to pneumothorax. So all of them you can mention as DD, but you have to keep the pulmonary embolism in first, and during the DD telling, you have to tell the points that goes against them. Let me give an example. The case I got in Bangalore, she was telling she was having pleuritic chest pain. Pleuritic chest pain means the pain was increasing after taking deep breath. So I can tell pulmonary embolism as my first DD. My second DD I can keep acute coronary syndrome because she is a smoker. My third DD I can keep pneumothorax, but I have to mention the points against pneumothorax. The point is there is no decreased breath sound on any part of the chest that goes that is against pneumothorax. Then I can also mention as my fourth DD as aortic dissection. But against that, the pain of the aortic dissection radiates to back. But this pain is not radiating to the back. Are you getting it, doctor?
Yes, sir.
Again, suppose you have got a case of right lower quadrant pain. There are many causes of right lower quadrant pain. It can be due to Crohn's disease. It can be due to ileocecal TB. It can be due to appendicitis. It can be due to ruptured ovarian cyst. In the PACES exam, suppose your diagnosis is Crohn's disease. So you have to keep it as first. For the second or third DD, like for the Crohn's disease, you can keep ileocecal TB also as a DD if you are giving an exam in the Indian subcontinent. But against appendicitis, you have to give some point. Like, I have not got any features that goes in favor of appendicitis. Just as a DD of right lower quadrant pain, I can mention appendicitis, but from the history and examination, I have not got any features in favor of this. Like the appendicitis pain starts in the right lower quadrant, then it radiates to the periumbilical region. But this pain is not like that. It can be ruptured ovarian cyst, but from the history and physical examination, I have not got any points in favor of this. So in this way, you can cover the full mark in differential diagnosis. In this course, for each given prompt, like the right lower quadrant pain, like the dysphagia, you are going to get a sets of differential diagnosis, which you can put every one of them in the DD. But you have to keep first which goes in favor of the given case. Then for the rest of the thing, you have to mention the others, but you have to also mention what goes against each of them. Is it clear to all the doctors?
Yes, sir. And sir, in concern dealing, we have to explain all of them to the patient or only the top one?
No, doctor. Only in simple language, only the main pathology. You don't have to discuss all the pathophysiology. It's not needed at all. And you don't have to discuss the management also, unless the patient wants to hear. If the patient wants to hear what is happening with me, he just tell, this is happening with you. Let him ask another question. Ask him, do you have any other question? Do you have any other concern? Is it clear, doctor?
Yes, sir.
Okay, this is how the differential diagnosis is covered. Then come to the clinical judgment. After you are done with the examiner, you are done with the patient, you will get 5 minutes to interact with the examiner. First, the examiner will ask you that, do you have any diagnosis or differential diagnosis? Based on this, he will give you mark in differential diagnosis. The second question is, what are the positive physical findings? Never mention the negative physical findings. They don't like this. Even if you are going to utter the negative physical findings, they are going to make you stop. They are just going to tell you that, don't waste my time. Just tell me the positive physical findings. If you don't get any positive physical finding, then tell, I could not appreciate any positive physical finding. And you will get full mark in this identifying physical signs. The third question is going to be, how will you like to investigate? And the fourth question is, how you are going to manage this case. Based on this answer, you will get mark in clinical judgment. So to get the full mark in clinical judgment, the main point is to know what to investigate and what to manage, how to manage. You have to tell this in completely professional way. And in this course, for all of the 240 cases, you are going to get a separate recording for the investigation, for the physical examination, investigation, and management. And you have to practice this. And my suggestion is, whenever you are going to give the answer to the examiner, never give the answer in one go. Let the examiner ask the question and give the answer in slow pace. Because if you are going to give the answer fast, the examiner is going to ask you more questions. But if you can reply the investigation and management in proper and professional way, it is very unlikely that he is going to cut any mark. But if you complete it earlier on, he is going to ask another question. He is going to ask you questions from whatever he can. Is it clear to all doctors how to get full mark in clinical judgment? Many of the candidates can think,
yes,
what books we have to read for passing the long clinical consultation. I will suggest that read a little bit less, practice a lot. For passing the clinical judgment, focus only on investigation and management first. Because,
sir,
yes, doctor.
From book, we mean like from where we have to practice scenarios, like in which book there are plenty of scenarios for practice.
Actually, in this course, if you enroll for this course, you are going to get more than 240 cases in details. That is not available at any book in the world.
Okay.
And I'm not personally aware of any book which covers all of this, like RIDER, OST. I have not got myself personally. And pardon for me if I make any mistake for that. So what mistakes candidate do? Like you may think that investigation management is very simple, but candidates make simple mistake. They forget to mention apart from basic investigation, and mark will be cut for that. For the UK, any investigation you order, you have to start with basic investigation first. This is a must to do. Then for the management, there are two types of cases in the PACES exam for LCC. One is acute case, another one is stable case. For the acute one, you have to start with admission first, then management of airway, breathing, and circulation. This is a must to utter word. This is simple, but candidates make this simple mistake. They forget to mention admission and management of airway, breathing, circulation for the acute cases. Then you have to start forming a multidisciplinary team, education and counseling. For the stable case, it will start on education and counseling and forming a multidisciplinary team. This looks so simple, but also candidate make mistakes here regarding the multidisciplinary team.
Sir, I have one question. Do we
Yes,
say
doctor.
only the basic test, or do we
Sorry.
enumerate the basic test?
Sorry, doctor.
Sir, do we say only the basic test we will do, or do we enumerate like complete blood count, LFT, KFT? We have to.
You can go with either. You can mention all the name. This is a
Okay.
wonderful way to kill the time, truly speaking. But you have to mention the basic test. Then for the management, if the case is acute, after admission, airway, breathing, and circulation, for both acute and stable, you have to do the education and counseling and forming a multidisciplinary team. And this is the multidisciplinary team. This is a must to do for each of the cases, because British examiner wants this multidisciplinary approach. They don't want you to know all the things. They want to assess you whether you are able to form a multidisciplinary team. And there is another trick here. The trick is there. Inside the multidisciplinary team, you have to know which member or what type of member you have to enroll here. Like this is a case of rheumatology. If you enroll here a neurologist and you have uttered the name of the neurologist, surely you are going to lose your mark. I'm telling it based on my personal experience, and I have talked to a lot of candidates who has faced the same. Let me give you some real example. During my first attempt in Bangalore, I got a case at cardiac short case station. That was a case of mitral stenosis. So I was able to make the diagnosis based on the murmur and physical examination. But whenever I was going to tell the management, I start with education and counseling, forming a multidisciplinary team comprising all the doctors. And I mentioned the term hematologist here. And I made the big mistake there. The examiner at that point stopped me and told me that I'm making some mock-like gesture, like, so you are going to refer this patient to hematologist for managing this mitral stenosis. I again just urged that before starting the work, I would like to take consultation from the hematologist. And I was having some arguing with the examiner. And later on, when the feedback came, I lost a lot of mark there. And this same thing has happened to a lot of candidates. Like in the rush of time, you may utter some name who should not be there. So my suggestion is only utter the term forming a multidisciplinary team. Don't go for the name of the members. Like you can, you may have a tendency to utter the name of the members, like physiotherapist, occupational therapist, psychologist, psychiatrist, neurologist, nephrologist. Don't go for that. You may fall into a trap that I suffered and a lot of candidates suffered. Only mention the word forming a multidisciplinary team. That will be enough. Is it clear to all the doctors?
Yes, sir.
Okay. Then how to manage the case, how to manage the complication and association, all of these stuffs you are going to get as a separate recording in this course for each of the 240 plus cases. So this is how you have to be prepared for the clinical judgment. Then managing patient concern, we have already discussed. Keep 2 minutes at hand at least to meet the concern, and try to meet the concern without using any jargon. It is very easy. It is, all of you will be able to meet the concern if you get enough time. Last is welfare. Welfare is that you don't have to get any pain to the patient. Like whenever touching the patient, take permission from them. Like whenever we're going to check the anemia, tell the patient, I'm going to touch your face. Is that okay with you? This will show the examiner that you are professional enough and you will get full mark in the welfare. Usually most of the candidates get full marks in this section. So it is very easy to pass. Just remember that we have to be very much careful in dealing with the patient. Sometimes the patient can tell you that some ADPKT case can have some tummy pain. So before palpating the tummy, ask the patient, do you have any pain at your tummy? If the patient complains of pain, then ask the examiner, that patient is feeling pain. Should I proceed or not? If you feel the pain, if you palpate the tummy on top of the pain, this will surely cut your mark. You have to take the permission of the examiner. If the examiner permits you, then you have to proceed carefully. Otherwise, it is not needed. If the examiner tells you that no needed at all, then you don't have to palpate the tummy, you will get full mark there. And this mark section is also important in the sense that the pass mark in this is 28. Sorry, let me. The pass mark is 28 out of 32. All of the 5 stations will have this welfare. So if anyone gets less than 28 out of 32, then he is going to fail. Not only fail, RCP will not give you the seat for the next diet also. This is truth. They'll give you some time to make yourself prepare to maintain the welfare. So that's all for the mark sheet, and this is very much important. Why I have discussed in detail of the mark sheet, because in this course, after taking preparation for the prompt session and for the PDF cases, all of the candidate has to practice with each other using this mark sheet. You have to practice how to judge each other based on each skill. It is true that in the initiation you will face mistake. You will face a lot of mistake, and you have to make this mistake. Otherwise, you will not run. And in this course, for the type 1 candidate, every day I will guide everyone personally how to judge each one based on market. Each type 1 candidate has to report me each day whether they have practiced with other candidate or not. If you don't report me, I'm going to poke you personally. And you have to be judgmental for that. So that's all for the mark sheet. May I know if anyone has any confusion regarding the mark distribution? Because once you acquire this, you don't have to depend on anyone else after this completion of the course. You will be self-sufficient to judge yourself and also to help others. You will be like a mentor. Any question from any of the doctors?
Hello, sir.
Yes, doctor.
So in case, for a case like for seizure, the driving has to be stopped and the candidate fails to tell anything for the patient regarding that. So in which skill the marks will be cut down? Is it in the clinical communication also?
Yes, clinical communication skill.
Okay, sir.
Good question. And in this course, each one has to be trained for which mistake, which mark will be cut. I train them personally. In the practice session also, I will make one judged by another. I will act like a surrogate and help other to judge, to give the judgment. I don't want to everyone make dependent on myself, because this is a one-time course and I allow no one to repeat this course, because every time you repeat and come back to me, I will not be able to give you anything else, something new.
For what duration this course is going to be?
Actually, the course access is provided until the candidate pass. And are you asking the course duration or the access duration? I'm not sure about that.
Course duration, sir.
Okay. Regarding the course duration, there are going to be two types of batch. Okay, let me show you the routine. Sorry, where is the routine? Here is. I was going to discuss this after the prom session, but for yourself, I'm discussing again. So here we are going to discuss the history taking session first. Like today is a GIT prom session. Then on 7 March, it is musculoskeletal. This whole routine was once given in the group. This is for the prom session. For the practice session, there are two types of batch. One is short duration batch, another one is long duration batch. The difference is that only in the duration. The short duration batch is going to be completed with 5 weeks practice. Each week, there are 2 practice sessions. Before the practice session, the prom session will already happen. After the prom session is done, each of the type 1 and type 2 candidate will gain access to some materials to take preparation and practice. And with the short duration batch, we'll have the GAT practice on 9, and on the long duration batch, we'll have the GAT practice on 10. For the short duration batch, each week there will be 2 practice sessions. So it will be covered with 10 sessions covering 5 weeks. But the long duration batch, it will have 1 practice session at each week. So it will take about 10 weeks to complete. Regarding this batch, actually, sorry to say, there's no slots available for the type 1 right now. Sorry, doctor. Okay. The contents are all the same, only the duration is different. So anyone who needs faster preparation is encouraged to enroll into short duration batch. And for the long duration one, I'm sorry, I'm not able to allow take any slot for the type 1 right now. Only type 2 and type 3 is available.
Sir, what is the difference between type 1 and type 2?
Okay, good question. Regarding type 1, they are going to get all the materials regarding prom session, the PDF cases, and the recording of the physical examination, investigation and preparation, and everyday personal supervision. Also with the one-to-one practice. During this practice session, I will assess each one separately. I will give exactly the same case from the given homework and assess them how they have practiced. This is for type 1. This is only for limited candidate. I will not be able to provide a lot of support to a lot of candidates. And for the type 2, they will get all the things except for personal guidance from me. And for the type 3, they will get the prom session access, also the practice session recording access, also live session recording. All of the cases, all of the sessions will be recorded and given to them. But the type 3 will not get the PDF cases and the physical examination, investigation, and management recordings.
So in type 2, will we get to participate?
Yeah, you can participate there, and you have to practice with other candidate. But you will not be able to practice with me directly during the practice session. That is the only difference.
So after this, you will have any other long duration course over?
Yes.
I'm giving type 3. I'm giving type 3, so I want to join the long duration course.
Yes, doctor. Everyone wants to join the long duration course. Actually, truly speaking, this long duration course has been started from this batch. It was not there for earlier batch. It was only the short duration. But what I saw that candidates could not complete the homework within this short period.
Yes, sir. And sir, I get very nervous when they start, doing every week 2 sessions, and even one session, I feel there's a lot to catch up, and I get very nervous actually. That's why I'm not doing any class. I'm doing only free session. I'm studying on my own because there's a lot of pressure. Do this, do not do that. I feel very scared of the exam.
Okay, regarding the next long duration batch, I'm not sure about that, but from the mid-July, another batch is going to be started.
Okay,
because
sir.
It will take 2 months to complete.
Okay, sir. And in this batch, if there is any vacancy, please let me know, sir.
Actually, there are lots of requests, and I am personally unable. Whenever there is any slot open, I will give a post at the group, and you just have to be care about, because there are lots of requests, and I am unable to take any slot for Type 1 for this long duration batch. And
So, sir, no problem, sir, because I am giving diet free. So I think in mid-July also it will be okay. July,
yes,
August.
yes,
So I
yes.
want to have to join at that time, sir.
Okay.
Please keep my name in reserve for that thing. Okay.
Actually, I'm unable to take any slot beforehand. You just
But
have
I
to keep.
June, mid-June, I will contact you.
You have to keep an eye on the group. Okay. Contact me later on. Let me complete the session, introductory session. It is still not completed because we have to discuss something else also. In this PDF, you will also get some diabetes questionnaire. These are very much important, and you have to make it by heart. You have to memorize it. Like what questions we have to ask whenever we'll get any patient with long-term diabetes. For type 1, it has to be more than 5 years. And for type 2, it has to be more than 10 years. If anyone is coming to you with 3 to 4 years or 2 to 3 years of diabetes, it is not needed to assess all the complications. So what are the questions we have to ask for any diabetic patient? First, we have to ask him general question. That is, do you have any high blood sugar for how long? If he mentions that he is having type 1 diabetes for more than 5 years or type 2 diabetes more than 10 years, then we have to ask the other questions. That how was it diagnosed? Was it diagnosed routinely or by some emergency? Because type 1 is usually get diagnosed by diabetic ketoacidosis presentation. Then what medication are you taking for this? Do you go to your eye doctor, kidney doctor, and food doctor at regular interval? Then may I know your 3 months average blood sugar report, which is called HbA1c. These are the general questions. Then we have to assess the compliance to the 3D. They are drug, diet, and daily exercise. For the drug, we have to ask, are you compliant with the medication? For the diet, we have to ask, are you following the recommended diabetic diet? For daily exercise, we have to ask, are you doing regular physical exercise? Then we have to look for the complication. The complication can be short-term and long-term. In the short term, the complication can be hypoglycemia or HHS or hyperglycemic hyperosmosis coma or diabetic ketoacidosis. So we just have to ask any episode of low blood sugar coma, that is hypoglycemia. It is very much important because if anyone has any episode of hypoglycemia, you have to stop the driving. So you have to assess for that. Then for HSS and DKA, we have to ask any episode of high blood sugar coma. This is the non-jargon term of hypoglycemia and DKA or HHS. Then we have to assess the complication. The complications are microvascular, macrovascular, and autonomic complication. Microvascular complications mean inside our body, wherever there are microvessels, the small size vessels that are affected by that has a chance to get affected by the diabetes, we have to assess them. They are nerve, they are blood vessels of the retina, and kidney. So you have to ask, do you feel any tingling or numbness at your hands or feet? That is for peripheral neuropathy. Any vision problem for diabetic neuropathy. And what about your urine? For diabetic nephropathy. This is for looking for microvascular complication. One of the doctor has asked how long the session will go on. Actually, after this introductory session, we'll start another session that is a prompt session of GAT. We'll discuss the approach to each of the prompt of GAT. It is going to take a time. So this is how we have to assess the nerve, the retina, and the kidney, that is microvascular complication of diabetes. Then for the macrovascular complication, we have to ask any weakness or previous episodes of weakness at any parts of your body, looking for stroke or TIA. Then to rule out MI or angina, any chest pain at rest or while walking. Then any pain at the back of your leg while walking. This is for peripheral vascular disease. So these three are the macrovascular disease. That is stroke or TIA, MI or angina, and peripheral vascular disease. Then let's come to the autonomic complication. The autonomic complications are symptoms of postural hypotension and diabetic autonomic neuropathy, that is gastroparesis. So to rule out the postural hypotension, we have to ask, do you feel dizzy standing from the sitting position? Whenever there is long-term diabetes, it affects the autonomic nervous system, resulting in postural hypotension. Whenever there is long-term diabetes, it is also going to affect the peristalsis of the GIT, resulting in decreased peristalsis. So we have to ask, do you feel full after eating? And also they can sweat a lot during eating. This is called gustatory sweating. We have to ask, any increased sweating while eating? These are all the symptoms of autonomic neuropathy, and you have to keep it memorized. I will suggest it from the PDF. Then, whenever there is gastroparesis, it will cause early satiety. Also, it will result in small intestinal bacterial overgrowth. These will result in diarrhea or loose motion. So, due to the gastroparesis, the patient can have constipation, but for the small intestinal bacterial overgrowth, the patient may have loose motion. So, this is something like alternative constipation and diarrhea. So, we have to ask, what about your bowel habit? Any loose motion? Any tight motion in between the episodes of loose motion? Then the last question is question of erectile dysfunction. If it is male, we have to ask, any problem in your intimate relationship? So these are all the questions for diabetes. I'm again repeating, if it is type 1 diabetes for more than 5 years and type 2 diabetes for more than 10 years, then we have to ask these sets of questions. And this is a very much popular case for PACES exam. At every diet, this case will come. You may be given a prompt of diabetic complication. This comes every now and then. And unless you memorize it beforehand, I think it will be difficult to reproduce it in the exam. So any question from any of the doctors from this diabetes questionnaire? Any confusion? Okay, let me proceed. There is some rheumatology screening question. I'm going to discuss it in the musculoskeletal prompt session. There are some sets of questions by asking which of them you can cover all the rheumatological disease. This is there, and we are going to have a detailed discussion on this at our next prompt session, that is the musculoskeletal session. And we have already discussed the case questionnaire for alcohol use. And that's all for introductory session today. May I know if anyone has any kind of question or confusion from this introduction, because this is going to be forming the base of your history taking. After that, we are going to start discussion on our, JAT prompts today. After taking about a 5 minutes break to give a rest to my voice. Before taking 5 minutes break, may I ask if
Sir,
any
I have
question?
a request.
Yes, doctor.
Can we do this prompt session after an hour?
Sorry, I could not get your point, doctor.
Like after a 1 hour break, can we do this session?
Actually, doctor, after a 1 hour break, it will be much late time here. So there are many doctors who have already enrolled and they are waiting for that. So we have to cover the prompt session.
Well, we will get the recording of the session.
Actually, this session will be recorded, and like every session, this for like every batch, this session will be uploaded at the YouTube channel.
Okay, then it's fine. Thank you.
Okay, doctor. So may I expect any question from any other candidate regarding the introduction or any part of the topics discussed today?
No, sir, it was a very nice introduction. Thank you so much.
I have a query. So
Good, doctor.
regarding the material, so
Yes.
do we get this after every session or after the course, after this complete
After every session.
after
Because
every session? Okay.
yes, because you have to do the homework and you have to take preparation for that. Right after you have to start the practice.
Okay.
And all the accesses regarding the recording will be there until the candidate pass the exam.
So homework means like I have to do the session and the
Okay.
another duration homework like.
Okay, let me give you the idea. Let me show you. So this prompt session will be uploaded in a separate Telegram channel. Also, apart from this, you will get some PDF of the cases, like from the GIT. There are 40 cases. These are some real PACES cases. If I open one case, so this is all the details of one case. Like this patient has come with swallowing difficulty. You will get all the things regarding case note of this patient, all the including differential diagnosis. So in this way, there are 40 cases, and these are real PACES cases. These are not my synthesized prompt-based cases. These are real PACES cases.
Okay.
So apart from this, you will get access to another thing, that is this thing. So these are some recorded video where you will get the sequence of physical examination for each of the cases separately, also with the investigation and management. So what you have to do, first from the prompt session, you have to make your own notes. Like if any swallowing difficulty comes in my PACES exam, I have to take the history, what differential diagnosis I have to consider, what screening question I have to ask. Then for each of the, you have to go through each of the PDF of the cases regarding the PDF and also the physical examination, investigation, and management. Then with the type 1 and type 2 candidate, you have to practice with each other. And you have to practice judging each other based on the mark sheet. And I will guide you if you face any confusion every day. And at the practice session, exactly from these 40 cases, I will throw one case randomly to see.
Okay, so the practice session will be held with the date on the 9th.
Yes.
Okay.
Yes.
Okay.
I will give exactly any one case to assess how you have gone through these cases. But you have to make your own notes beforehand, and you have to know what to ask. I don't prefer going for any blind practice. Like I can throw some random case to you and assess. I don't like this kind of approach to it.
Okay.
So any other question? If there is no question left, then I'd like to take 5 minutes break. After that, we will start our GAT session to give some 5 minutes break to my voice. Okay, doctors, then see you later after 5 minutes. I'm just coming back. Let me stop the recording.